Hello, my name is Chichi Johnson, and this is the Population Health Assignment to develop and execute an evaluation plan from population health data. I will be leading a team that is focused on the big data and healthcare planning for maternal mortality. My professor is Dr. Denise Zabriskie, and this is the population health on maternal mortality. So this presentation will cover all these table of content from objectives to references, and please feel free to jump around. For the objectives of this presentation, I would, with my team, will develop a collaborative intervention to address maternal mortality with as a team. We'll focus on the big data to appraise essential information for healthcare planning. We'll utilize data collection, current literary evidence, and leadership skills to develop and implement nursing interventions specific to the health of women. The team will analyze big data and utilize findings to support best practice and organizational outcomes. And we're also going to apply research and data analysis skill, in this case, data mining, to address health disparities and healthcare delivery issues with women in the United States and globally. So maternal health refers to the health of women during pregnancy, childbirth, and postnatal period. Each stage should be a positive experience, ensuring women and their babies reach their full potential for health and well-being. The death of a woman during pregnancy, at delivery, or soon after delivery is a tragedy for her, for the family, and for the community. So some of the key facts that were discovered for this, for maternal mortality, is that every day in 2017, approximately 810 women died from preventable causes that are related to pregnancy and childbirth. Between 2000 and 2017, the maternal mortality ratio, which is the maternal death per 100,000 live births, dropped by 38% worldwide. 94% of all maternal deaths occur in low and lower middle income countries. Young adolescents ages 10 to 14 face a higher risk of complications and death as a result of pregnancy than other women. Evidence showed that skilled care before, during, and after childbirth can save lives of women and children and newborns. The high number of maternal deaths in some areas of the world reflects inequalities in access to quality health services and highlights the gap between the rich and the poor. The maternal mortality ratio in low-income countries in 2017 is 462 per 100,000 live births versus 11 in developed country per 1,000 live births. In 2017, 15 countries were considered to be very high alert or high alert, and these are South Sudan, Somalia, Central African Republic, Yemen, Syria, Sudan, the Democratic Republic of Congo, Chad, Afghanistan, Iraq, Haiti, Guinea, Zimbabwe, Nigeria, and Ethiopia. And these 15 countries had the maternal mortality rates in 2017 ranging from 31 in Syria to 1,150 in South Sudan. The risk of maternal mortality is highest for adolescent girls and under 15 years of age, and complications in pregnancy and childbirth are higher among adolescents ages 10 to 19 compared to women ages 20 to 24. Women in less developed countries have, on average, many more pregnancies than women in developed countries. And in their lifetime, risk of death due to pregnancy is higher. A woman's lifetime risk of maternal death is the probability that a 15-year-old woman will eventually die from a maternal cause. In high-income countries, this is 1 in 5,400 versus 1 in 45 in low-income countries. Research showed that when it comes to developed countries, the United States has the highest rate compared to Greece, United Arab Emirates, Ireland, United Kingdom. So why do women not get the care they need? Well, according to our research, poor women in remote areas are the least likely to receive adequate health care. This is especially true for regions with low numbers of skilled healthcare workers, such as sub-Saharan Africa and South Asia. The latest available data suggests that in most high-income and upper-middle-income countries, more than 90% of all births benefit the presence of a trained midwife, doctor, or a nurse. However, fewer than half of all births in several low-income and lower middle-income countries are assisted by such skilled health personnel. The main factors that prevent women from receiving or seeking care during pregnancy and childbirth are poverty, distance to facilities, lack of information, inadequate and poor quality services, cultural beliefs and practices, closure of rural hospitals and obstetric programs. To improve maternal health, barriers that limit access to quality maternal health services must be identified and addressed at both health system and societal levels. Maternal mortality, there are 3 commonly used measures of maternal death in the United States. While they all capture some aspects of maternal death, they are not equivalent. So the need for maternal death data in the fight to reduce maternal mortality was introduced in 2017 by a bill called the Preventive Maternal Death Act of 2017. The new law directs the Department of Health and Human Services to establish a program that will support states' efforts to establish or expand maternal mortality review committees, collect consistent and standardized data, work with the State Department of Public Health on maternal mortality prevention strategies, and eliminate maternal mortality disparities. The measures of maternal death in the United States are, data was collected for pregnancy-associated death. This means death while pregnant or within 1 year of the end of the pregnancy, irrespective of the cause. The second one is pregnancy-related death. Death during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by the pregnancy, or the aggravation of unrelated condition by the physiologic effects of pregnancy. This is used in the US only, and this CDC measure is typically reported as a ratio per 100,000 births. The maternal mortality is defined as the death while pregnant or within 42 days of the end of the pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. This is used by the World Health Organization in international comparisons. This measure is reported again as a ratio per 100,000 births. So the CDC collects maternal mortality data using 3 national surveillance systems: the Pregnancy Mortality Surveillance System, which is PMSS, the National Vital Statistics System, NVSS, the Maternal Mortality Review Information Application, MMRIA. The CDC collects this data to help to fill the data gap about causes of maternal death. The first year of data reporting was in 1987. CDC conducts the National Pregnancy-Related Mortality Surveillance to also better understand the risk factors for and causes of pregnancy-related deaths in the United States. The Pregnancy Mortality Surveillance System, PMSS, defines a pregnancy-related death as the death of a woman while pregnant or within 1 year of the end of pregnancy from any cause related to or aggravated by pregnancy. It's used, the PMSS is used to calculate the pregnancy-related mortality ratio, an estimate of number of pregnancy-related deaths for every 100,000 live births. The data does not include death due to injury. This definition and time frame are consistent with that used by the World Health Organization for reporting on maternal mortality rates. The PMSS also uses vital records for identification of deaths, including description of causes of death and pregnancy status information on death records. PMSS further uses the linkage of death records of women of reproductive age to birth and fetal death records within 1 year of the death. They also use media searches and reporting from public health agencies and from healthcare providers and the public in the identification process. So the PMSS deaths are reviewed by medical epidemiologists who perform an in-depth review of vital records and other data as available, such as medical records, autopsy reports, for each death to determine the pregnancy-related mortality ratio. So these linkages and the review processes, of course, result in slower reporting than the National Vital Statistics System, NVSS. The National Vital Statistics System, the National Center for Health Statistics receives copies of electronic records for deaths from all states and jurisdictions, such as District of Columbia. Then uses this death certificate information to assign ICD-10 codes based on the cause of deaths. According to CDC officials, the National Center for Health Statistics uses these coded records to compile national vital statistics files in NVSS, which is the source of official statistics of mortality in the United States, including maternal deaths. The NVSS data are used to identify national trends and make international comparisons. The NVSS uses the term maternal death as defined by the World Health Organization to mean the death of a woman while pregnant or within 42 days of pregnancy, irrespective of the duration and site of the pregnancy from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. The term does not include late maternal deaths, which occurs more than 42 days, but less than 1 year after pregnancy. The maternal mortality rate is the number of maternal deaths during pregnancy or within 42 days of pregnancy per 100,000 live births as defined by the World Health Organization. The Maternal Mortality Review Information Application, MMRIA, or known as Mmr, in 2017, the CDC released this data in which multidisciplinary maternal mortality review committees at state and other jurisdictional level can review pregnancy-related death. They can collect and review data from various sources, such as medical records, social services records, autopsy reports, vital records, to determine preventability and identify factors that contributed to those deaths, as well as prevention strategies to address the committee's identification. The maternal mortality review committees identify an average of 3 to 4 contributing factors per pregnancy-related death based on information collected through MMRIA, such as community factors like unstable housing, health facility factors like limited experience with obstetric emergencies, patient factors like lack of knowledge, provider factors like delayed diagnosis, and system-level factors like inadequate access to care and poor case coordination. The enhancing review and surveillance to eliminate maternal mortality, known as ERASE-MM. The maternal mortality review committees also in different states and cities, we also use this data to perform comprehensive review of deaths among women within a year of the end of a pregnancy. Tracking maternal death is inconsistent and often incomplete at the national and state levels. Access to consistent, high quality, and reliable data that identify both the characteristics of women who die due to pregnancy complications and the specific circumstances that lead to those deaths is essential to inform critical action steps and for developing strategies to prevent maternal mortality. Challenges remain with respect to shared terminology, definitions, and accuracy of maternal mortality data. There continues to be a need for better data to understand the trends and causes of maternal death and to inform preventative efforts to reduce maternal mortality. Since the early 2000s, the United States have been working to improve its surveillance of maternal mortality. A key improvement has been the addition of the pregnancy checkbox question to the US standard death certificate in 2003. This question was added after studies identified underreporting of maternal deaths during the 1980s and 1990s. However, prior to the addition of the pregnancy checkbox, there was a general concern that the United States was not identifying all of the maternal deaths and thus did not have a full picture of maternal mortality. Since that time, growing evidence suggests that the addition of the checkbox may have resulted in misclassification and overreporting of maternal deaths. Therefore, experts continue to call for further improvements in data collection to ensure accurate reporting of maternal death. A greater proportion of deaths where the pregnancy checkbox on the death certificate was marked incorrectly were for women aged 45 and older. In January 2020, the CDC released the first official Mmr Statistics since 2007, with accompanying methodology reports, including changes in coding to account for erroneous reporting of maternal deaths due to the adoption of the pregnancy checkbox. Because maternal mortality review committees use data sources beyond vital records, they are best poised to accurately identify, comprehensively review, and specifically recommend actions that prevent mortality and morbidity. Since the pregnancy morbidity surveillance system was implemented, the number of reported pregnancy-related deaths in the United States steadily increased from 7.2 deaths per 100,000 live births in 1987 to 17.3 deaths per 100,000 live births in 2017. To collect the additional data, CDC official annually send requests to vital records offices for all 50 states and other applicable jurisdictions to provide the death certificates, linked live births and fetal deaths, and other supporting information for deaths with an ICD-10 Chapter 0 code for the previous year, and all deaths for any cause, including injury or trauma among women who were pregnant or were within 1 year of pregnancy as identified by the matching the death certificate to the birth or fetal death certificate. According to CDC and related literature, linking information on death certificates to information on infant births and fetal death certificate can help confirm that the pregnancy checkbox on the death certificate was completely accurate. In addition to confirming validity of pregnancy-related deaths as indicated by the checkbox, linking information on death certificates to infant birth or death, fetal death certificate can identify pregnancy-related deaths where the checkbox did not indicate a pregnancy, but should have. So like in false negatives. CDC officials said that PMSS data are considered the most reliable source of national data on pregnancy-related deaths because the PMSS links death certificates with birth or fetal death certificates and additional information when available, like hospital records. Also, these files are reviewed by medically trained epidemiologists to determine if the cause and the time of death are related to pregnancy. So with the data pertaining to this disease from AHRQ and CDC and the World Health Organization, it shows that women in the US are most likely to die from complications related to pregnancy or childbirth. In 2018, there were 17 maternal deaths per every 100,000 live births in the US, a ratio more than double that of most other high-income countries. In contrast, the maternal mortality ratio were 3 per 100,000 or fewer in the Netherlands, Norway, and New Zealand. Approximately 3 in 5 maternal deaths each year, about 420 deaths, were likely preventable. This is consistent with multiple studies showing more than 50% of maternal deaths evaluated had at least some possible preventability, and that multiple opportunities for improvement and prevention of morbidity and mortality exist at the policy, system, facility, clinician, and patient levels. Significant disparities continues to persist with rates highest among non-Hispanic Black women, which averages 43 per 100,000 live births, and American Indians, Alaska Natives, which averages 33 per 1,000 live births. As compared to Asian Pacific Islanders, non-Hispanic women, which averages to 14 per 1,000 live births, white non-Hispanic women, 13 per 100,000 live births, or Hispanic women, 11 per 100,000 live births. A relatively large share of pregnancy-related deaths in the United States occur after birth. To better understand the high maternal death rate in the United States, it is helpful to know that when they happen, 17% of deaths occur on the day of delivery. 52, which is half of the deaths, percent occur after delivery or postpartum. 19% of these 52 of all maternal deaths occur between 1 and 6 days postpartum. 21% of all maternal deaths are between 1 and 6 weeks postpartum, and 12% of all maternal deaths take place during the remaining portion of the year. These are also known as late maternal deaths. For the remainder of this presentation, I will discuss how the team used the current evidence scholarly overview and the proposed an intervention. The team also looked at the causes and practice initiatives, budgeting and cost effectiveness of the initiatives, the program impact, and methods of evaluation of the intervention. So maternal mortality is a central event in assessing the quality of the healthcare system as a whole. For the last 50 years, African-American women in the United States have experienced a 3 to 4 times higher mortality rate as a result of pregnancy and birth complications than white women. This rate appears to be independent of age, education, or the number of children they have had. Factors linked to an increased risk of maternal mortality include being 35 years or older, less educated, obesity, lack of adequate prenatal care. Among women, those pregnancies resulted in a live birth. The risk of pregnancy-related death increased after 20 weeks of pregnancy and with the birth of a 5th child. This risk is also higher in both first 12 weeks of pregnancy and after the 23rd week. A recent report showed that cesarean delivery was 10 times more likely than vaginal delivery to result in the death of a mother. 85% of maternal deaths were unrelated to any pre-existing medical condition, meaning that the vast majority of these pregnancies were originally considered low risk. So it's important for all women of reproductive age to adopt healthy lifestyle, such as maintaining healthy diet and weight, being physically active, and quitting all substance use and preventing injuries, and address any health-related problems before getting pregnant. Contributing factors and prevention strategies were identified at the provider, patient, community, health facility, and system levels. Some of these prevention strategies include for healthcare providers to help patients to manage chronic disease, communicate to patients about warning signs, and use tools to flag warning signs early so women can receive timely treatment. Health facilities can standardize coordination of care and response to obstetric emergencies and train non-obstetric providers to consider recent pregnancy history when they're doing histories. Women and their families can know when to communicate about symptoms of complications and note pregnancy history anytime medical care is received within the year after delivery. The states and communities can assess and coordinate delivery hospitals for risk-appropriate care and supports reviews of the causes behind every maternal death, because more than half of pregnancy-associated deaths occur later than 42 days postpartum. So it's important to continue tracking and monitoring deaths out of up to 1 year after pregnancy. 2/3 of pregnancy-related deaths occur during pregnancy or within 1 year of pregnancy. So less than 1/3 of violent deaths occur while the woman was pregnant or in the first 3 months postpartum. More than half of violent deaths occur at least 6 months after pregnancy. So there are different opportunities for prevention, like looking more broadly at postpartum period, access to care, especially specialty care and behavioral health services is still an issue. So having access to behavioral care is very important, even for women with or without insurance. Providers do not know where to refer postpartum women with mental health and substance use disorder. Studies also show there are inadequate provider skills, and these tend to reduce the quality of care, and there is a need to educate all provider types how to treat postpartum women. There is a limited public awareness about postpartum health problems and concerns. Lack of care coordination is a universal issue for all women. Hospitals should have clear policies and procedures around the identification and treatment of postpartum women. And policies should be consistent across all hospital departments. Women die as a result of complication. So there are many causes. Most of these complications developed during pregnancy, most of them, as I mentioned, are preventable. Other complications may exist before pregnancy and are worsened during pregnancy, especially if they're not managed. To improve maternal health, barriers that limit access to quality maternal health services must be identified and addressed by the health system and at societal levels. All women need access to high quality care. And all births should be attended by skilled health professionals. And all births must be timely managed, and treatment can make the difference between life and death of the mother and the baby. Some of the causes of death is severe bleeding after birth can kill a healthy woman within hours if she's not unattended. So injecting medications that can stop bleeding immediately after childbirth can effectively reduce the risk of bleeding. Infection is another reason that childbirth can be dangerous and needs to be eliminated. So good hand hygiene should be practiced, and if early signs of infections are recognized, they should be treated in a timely manner. Preeclampsia should be detected and appropriately managed before the onset of eclampsia that comes with convulsions. Giving max sulfate for preeclampsia can help lower the woman's risk of developing eclampsia. To avoid maternal death, it's also vital to prevent unwanted pregnancies. So all women, including adolescents, need access to contraception, safe abortion services to the full extent of the law, and quality post-abortion care. In the first week of postpartum, severe bleeding, high blood pressure, infection are the most common contributors to maternal death. However, cardiomyopathy is the leading cause of late deaths. Researches show that United States women experience more late maternal death than women in other high-income countries. The high US maternal mortality rate are multifaceted and diverse and more than one reason. Findings suggest that undersupply of maternity providers, especially midwives, and lack of access to comprehensive postpartum support can be contributing factors. In the United States, there is an overall shortage of maternity care providers, both OBGYNs and midwives. In other countries, midwives outnumber OBGYNs. Although a large share of maternal deaths occur post-birth, the US is the only country that does not guarantee access to provider home visits or paid parental leave in the postpartum period. Also, the US has a relatively undersupply of maternity care providers. In most countries, maternity care is integrated with other primary care, and midwives play an important role. During the COVID-19 pandemic, as demand for midwifery care has grown in the United States, several states issued emergency order expanding midwifery services to pregnant women. Some of these states are like Maine, New Jersey, and New York. While the Affordable Care Act requires Medicare to pay for midwifery care that are provided in the freestanding birth centers, more needs need to be done to expand access to services and make midwives more affordable. Countries also have rapidly reorganized their maternity care delivery system during COVID-19 to expand the use of telemedicine and the capacity to provide home births. To strengthen maternity care during the pandemic, the US could look to countries with long-standing experiences in home birth and midwifery-led care. For postpartum care, the World Health Organization recommended at least 4 health contacts in the first 6 weeks. Yet, in US, women typically have a single office-based physician visit within this period, and some women don't even have any visit at all. So expanding the eligibility for Medicaid, which pays for 43% of US deliveries, can lead to more stable postpartum coverages. Currently, the program coverage extends to only 6 weeks postpartum. Some states are trying to expand the coverage to up to a year. The US is the only high-income country that does not guarantee all mothers paid maternity leave. Although a few states have recently introduced some paid leave, women receiving paid leave use fewer healthcare services compared to women with only unpaid leave. The racial disparities continue to show that the divide between rich and poor in the United States. The number of births per 100,000 births for vulnerable and marginalized groups like Blacks, Hispanic, Asians are higher than white mothers. The pandemic has also potentially exacerbated the existing US racial disparities in maternal outcomes. Black and Latino people have faced higher rates of economic hardship and mental health problems during the pandemic compared to their white counterparts. Pregnancy-related mortality for Black and American Indians and Alaska Native women is 2 to 3 times higher. These disparities are not unique to just the United States. In the United Kingdom, which has universal health coverage, maternal deaths were 5 times more common among Black women in the pre-pandemic period and 2 times more common among Asian women. So achieving equity in maternal outcome remains a global challenge. The well-being of mothers should be a top policy priorities for all countries. In the United States, where maternal health outcomes are poor relative to other parts of the world, policymakers and delivery system leaders can examine international models of maternity care to inform strategies for improvement. So there are national and global initiatives to prevent maternal mortality in this country. For instance, implementing a maternal health and pregnancy outcome vision for everyone. It's known as Improve initiative. It aims to mitigate preventable maternal mortality and promote health equity by using an integrated approach to understand biological, behavioral, sociocultural, and structural factors. Another initiative, Maternal and Pediatric Precision in Therapeutic Hub, Imprint. The goal of the hub is to establish a center of knowledge that explains what drugs pregnant and lactating women can take safely and the effects of those medications on the babies. So these initiatives, and these are just two, there are several. These initiatives are supported by some federal fundings and initiatives. For instance, the Preventing Maternal Death, supporting maternal mortality review committees, has funding. In 2019, CDC awarded 24 5-year cooperative agreements, and the recipients received between 150,000 to over 550,000 in funding each year for a total funding amount of 8.4 million across all awardees for the fiscal year of 2019. And the purpose is to support maternal mortality review committees, the ability to collect the most comprehensive, detailed data on causes and circumstances surrounding pregnancy-related deaths to develop recommendations for prevention. This multidisciplinary approach encourages collaboration with clinical and non-clinical partnership to improve quality of care and address social determinants of health to reduce health inequities. The short-term outcome is timely, accurate, and standardized information available about deaths to women during pregnancy and the year after the end of the pregnancy, including opportunities for prevention within a funded jurisdiction and across funded jurisdiction. And the long-term outcome is to reduction in maternal complication of pregnancy. So there are other initiatives that are willing, other funding initiatives that are willing to fund any initiative to prevent and mitigate the effects of maternal mortality in the United States, as long as they support research, collection of data, enhancement of any state perinatal quality collaboratives, support those collaboratives nationally, support national digital campaigns to provide information about the risk factors, about signs and symptoms of causes that might potentially cause deaths like DVTs, support promotion of health and well-being before, during, and after pregnancy, programs that will support the development and implementation of non-hospital focused maternity safety, and provide support for recipients to hire clinical providers to provide direct access to women, and support efforts to improve access and continuity of maternal and obstetrical care in rural communities, and programs that will strengthen partnership and collaboration by establishing a state-funded, state-focused maternal health task force, and programs that will support improving maternal health states and key stakeholders in their efforts to reduce and prevent maternal mortality and severe maternal morbidity. So all these program initiatives do have a lot of money that they're willing to invest in any strategies that will help to support all these objectives and outcomes. So another thing I want to add here is the Affordable Care Act. The Affordable Care Act is actually a strategy to help to improve access to maternity care. So with the Affordable Care Act, it forced the insurance to no longer deny coverage to pregnant women who apply for insurance, because they could usually consider pregnancy as pre-existing condition. Also, the insurers are no longer allowed to charge women higher health care premiums than they charge men, because usually this was a common practice, because as women were anticipated to have higher healthcare costs, especially around childbearing years. And because of ACA, insurers are only allowed to charge higher premium based on age and tobacco use, not because somebody is at the age of childbirth. Free preventative services, insurers must provide preventative services such as breast cancer screening, cervical cancer screening, and contraceptives and osteoporosis screening and chlamydia screening for any woman, whether they're childbirth or at risk, without co-payments or co-insurance or any cost sharing. The essential health benefits are also included with the ACA. All individual, marketplace, or small group insurance plan must cover 10 essential health benefits, including maternity coverages. The ACA forces the support for new mothers. Employers with at least 50 workers must allow nursing women breaks at work to express breast milk, and they must provide a private place for these women to do that. There is the ACA the provision calls for expanded Medicaid eligibility, so that individuals with incomes up to 138% of the federal poverty level can enroll in Medicaid. And this, even though it's left to the state's discretion, 38 states and District of Columbia have opted to expand their Medicaid program. And this is great, especially for women, single women. Premium subsidies for low-income women are also available for all individuals earning up to 400% of the federal poverty level. So for like a single person would be like 51,000, and for a family of 4 would be like 104,000. So they will get these subsidies. There are coverage for young women. So young women can stay on their parents' plan until their 26th birthday, instead of being kicked out when they reach 25. As I mentioned before, midwives that are practicing in freestanding birth centers can be reimbursed to the amount of what they will pay physicians if they offer the same services. But finally, the most important provision of ACA is the creation of the Maternal, Infant, and Early Childhood Home Visiting Program. So about 154,000 parents and children in 1,000 US counties receive home visits through this program created by the provision of Affordable Care Act. So Affordable Care Act is actually can be seen as a strategy that will help to improve access to maternity care. The US is one of the few countries in the world where maternal mortality is reportedly on the rise. And my suspicion is that United States has better data collection strategies. And that's why we're reporting accurately. And that some of the other countries, that their data strategies may not be that accurate. However, the US, because of these data, the US spends $111 billion every year on maternal and newborn care. The cost effectiveness of intervention is the measure of its impact in terms of life years saved, or the effect of morbidity and mortality versus per person delivery cost of that intervention. So the UN Secretary General Ban Ki-moon estimated that the global financial impact of maternal and newborn deaths to be 15 billion per year in lost productivity. Cost effectiveness analysis often then is an underestimate of the total economic benefit of promoting an intervention. Intervention for maternal health encompasses various approaches, including promotional, preventative, and therapeutic. Promotional intervention target populations with health promotion campaigns and counseling, such as advocating, reproductive health, family planning, care seeking, and antenatal care during pregnancy. Preventative interventions include, but are not limited to, provision and availability of contraceptives for birth spacing and safer sex, and the provision of clean delivery kits. Treatments include the use of skilled birth attendants and postpartum hemorrhage care. Of the wide array of interventions, and studies and literature show that the majority of the most cost-effective are preventative interventions. So the long-term benefits of the nation's investment in maternal health are best measured through improved physical, mental health, better quality of life, and the prevention of premature deaths in women. Pregnancy-related deaths of women cost about 15 billion, according to UN Secretary. And these deaths are economic losses are nearly 100% preventable. So making the investment early in life reaps benefit throughout the adulthood and often into the next generation. The health benefits have economic value, as well as through reduced healthcare costs, educational gains, improved productivity, and other benefits to individual and society as a whole. By preventing death and disability and improving health outcomes over the lifespan of these interventions will reduce healthcare costs in the long run and provide economic value to the society. Safe motherhood interventions save a significant number of maternal mortality and morbidity and lives of children. So in addition, women contribute most of the unpaid work, such as cooking, caring for children, the sick, caring for the elderly. And women's unpaid work equals about 1/3 of the world's gross national product. This type of work has national economic implication because it saves expenditures and replaces income in time of economic crisis. Women in some vulnerable populations are the sole income earners in nearly 1/3 of all households globally. Many maternal care interventions are proven to be both effective in reducing maternal death and cost-effective, especially in these high-risk groups. So investing in maternal health has valuable equity benefits, since differences in maternal mortality mirrors the huge discrepancies between the rich and the poor, since poor women are especially vulnerable during pregnancy and they tend to live further away from health facilities. So improving maternal health contributes more broadly to poverty reduction. Using gross national product per capita as a benchmark, against which to consider the cost per disability adjusted life year averted, cost per quality adjusted life year gained, and cost per life year saved. All the strategies that report these measures should be considered cost effective. So for instance, if you use, looking at using some of the interventions that we use in the clinical setting to avert preeclampsia and eclampsia, or retain products of conception, or stop bleeding, or even safe abortion services. Those have actually proven to show they offer the highest benefit cost ratio. The BCR, benefit cost ratio, is an indicator. It's used in cost benefit analysis to that attempts to summarize the overall value of money of a project. So as you can see, using some of these intervention increases the benefit cost ratio. So it's proven that any intervention to save a woman's life will actually is very cost effective, maybe not immediately, but in the long term. So for instance, in the basic, if you use basic emergency obstetric and newborn care with family planning, the cost is like $71.50 worth of benefit for every $1 spent by the government. So this will require 2.9 billion per year in additional investments and will avert an expected additional 162,000 maternal deaths and 1.2 million newborn deaths and 1.18 million stillbirths. So it's very, even though it's expensive initially, in the long run, it's very cost effective. So the foremost cost-effective individual intervention where only maternal deaths averted were included, were interventions that prevented death due to some of the other causes like intervention that prevents death due to hypertensive disease, hemorrhaging. So these are among the most common causes of maternal death. The other top intervention reducing mortality can also be due to sepsis and abortion. Family planning led to a large decrease in the number of maternal deaths by preventing unintended or risky pregnancies. So all that can be very cost effective in the long term. So for this population health problem, the team and I decided that we're going to use the care model for perinatal health. The care model provides the framework for system level improvements that will yield optimal pregnancy results. It identifies the essential elements of healthcare system that encourages high quality care. The models also include evidence-based change concept designed to foster productive interactions between informed patients who take an active part in their care and providers who are prepared with resources and expertise. Research shows a wide range of community-based approaches could improve maternal health outcomes and patient experiences while also potentially reducing costs. Such approaches could easily benefit those most at risk for poor outcomes, especially people of color and those with low income. One policy option is expanding reimbursement for providers like doulas and midwives, whose care has been associated with improved maternal and infant health outcome in some research. So enhancing patient access to broader range of services and even incentivizing health systems and providers to adopt evidence-based, equity-centered models of care, such as group prenatal care, pregnancy medical homes, freestanding birth centers, community-based doulas and midwives. Community-based doulas and midwives, they are trusted. They're usually in the local communities. They're trained to provide psychological, emotional, and educational support during pregnancy, childbirth, and the postpartum periods. So getting these personnel can actually help in reducing maternal mortality in populations that are usually paranoid or scared of healthcare system. So the evidence suggests that doulas are beneficial. They're usually for women of color, for low-income women, and other marginalized groups. So far, at least 5 states, Indiana, Minnesota, New Jersey, New York, and Oregon, have passed legislation implementing third-party reimbursement for doula services through Medicaid. Now, as we mentioned before, midwives are also very an extensive literature review shows that midwife-led maternity care results in substantially higher rates of vaginal delivery and lower rates of C-sections. Freestanding birth centers standalone facilities that provide prenatal and labor and delivery care. These centers emphasize relationship building between providers and the patients, and the birth centers, birth planning, and labor. So birth centers reduce the number of interventions used in the course of labor and delivery, saving at least 1,000 per birth. Culturally sensitive birth centers are a promising means of reducing racial disparities. And in a recent studies, more than 15,000 birth center laborers found only 6% resulted in C-section with no maternal death. That's big. For group prenatal care, it has been widely tested as an alternative to traditional and individualized care. So with the group prenatal care, the group, the convener, pregnant patients convene as a group to facilitate discussions on topics ranging from preparation for parenthood and stress and breastfeeding and nutrition and labor and delivery. There is evidence that group prenatal care is particularly helpful for improving health outcomes among marginalized groups with low income, suggesting that the model can help reduce racial disparities. However, the team and I were very fascinated about the pregnancy medical home. The pregnancy medical home provides comprehensive perinatal health care. It provides early prenatal care in the first trimester. It expanded patient access through increased office hours, engages patients in shared decision making. There is a promising evidence that PMH model with its integrated care teams will address behavioral health, social needs, and could play a role in reducing racial disparities in maternal outcome. The literature talked about a medical home pilot in Texas that resulted in better outcome, fewer emergency department visits, fewer C-sections, and pilots in Wisconsin and Texas showed that there is increased likelihood that patients will attend postpartum visit. So for example, in North Carolina, which has the second lower rate of maternal mortality of all 25 reporting states, according to 2018 data from CDC, the state's success in part may be the result of its PMH model, which was implemented among 95% of prenatal care providers who accept Medicaid payment. So it does look, first of all, it works. Yes, you may need a lot of funding initially, because you have to hire health navigators to be able to reach out to patients as reminders about prenatal care and all that. But in the long run, it reduced mortality and morbidity of this population as a health outcome. So for the goals and objectives, the team and I decided that we're going to develop it from the World Health Organization's 5 defined global and national targets for 2025, the Ending Preventable Maternal Mortality Initiative. So this initiative includes a broad coalition of partners working in maternal and newborn health, and has established a new coverage targets and milestone that need to be achieved. So some of these 5 targets are that 90% pregnant women should attend 4 or more antenatal care visits. 90% births should be attended by skilled health personnel. 80% women who have just given birth to should access postnatal care within 2 days of delivery. 60% of population should have access to emergency obstetrical care within 2 hours of travel time. And 65% of women should be able to make informed and empowered decisions regarding sexual relations, contraceptive use, and their reproductive health. So we decided to go with number 1 because which is that 90% of pregnant women should attend 4 or more antenatal care visits. It should be increased to up to 8 visits by 2030. So we went with the number one because we realized that prenatal care is important for the health of a mother and of course the baby. Unfortunately, too many women do not seek care when they learn that they're pregnant, and that may result in an increase in undetected high-risk pregnancies, increase in cesarean section, and of course, increase in premature for the babies too. So mothers who do not receive prenatal care are more likely to deliver a low-weight baby, and they are more likely to have increase in mortality rate. So by targeting prenatal care from very early on and continuing throughout the pregnancy, we consider, and we supported by literature, that it's one of the most effective interventions to reduce prematurity, improve birth outcome, and of course, decrease maternal mortality. So early prenatal care support is very important. Healthcare providers should monitor the health of the mother and identify any health conditions. It's also important for time for providers to educate the mothers on a variety of health issues related to pregnancy, prepare mothers for childbirth, teach them about, what to expect, nutrition and all that. And when we look at the impact of this, the risk factors, the earlier the intervention, the better. So the team, we decided to use A3 process for this initiative, this project. The A3 process is a structured template for solving problems in a continuous manner. The A3 approach is also known as the systemic problem solving. The approach is based on the principles of plan, do, check, act. So systemic problem solving, the A3 process, introduces the concepts of project definition, development of the root cause analysis, and the implementation of the solution. The reason for the A3 approach is to provide a structure to problem solving and to help the team determine what caused the problem. The Six Sigma and Pdsa A3, so Six Sigma A3 and Pdsa are interrelated. The key elements of A3 Six Sigma is related to Pdsa as follows. The plan phase of the Pdsa is related to define the core processes, the key stakeholders, the patient's requirements of the Six Sigma. The do phase of the Pdsa is related to measure performance of the Six Sigma. The study phase of the Pdsa is related to analyze of the Six Sigma, and the act phase of the Pdsa is related to improve and integration of the Six Sigma. I know it's not as very clear with the different, but the next few slides, I'm going to kind of take apart this A3 and talk about what we did and what we intend to, our intended outcome. What do we want to see after we finish? So the first is the root cause analysis. So root cause analysis is a technique used to identify trends, assess risk that can be used whenever human error is suspected, with the understanding that it's the system rather than the individual factors that are likely the root cause of most problems. So this is not about blaming, it's looking at the system to see where the error happened in the system that we can fix or that we can find a solution for. The maternal mortality, they identify root cause analysis, identify some of the things we've discussed in this presentation already, like complications during and following pregnancy and childbirth, the policy implications, and the barriers to quality maternal health care and other barriers. So with complications, we're looking at, some of the outcomes after pregnancy, like severe bleeding, infections, unsafe abortion, high blood pressure, and chronic conditions like cardiac and diabetes. For barriers to quality maternal measures, we're looking at cultural beliefs, lack of information, distance of the mother to the facilities, poverty, inadequate or poor quality services. For policy implications, we're looking at limited midwifery services, racial disparities, limited guaranteed paid maternity, and of course, limited postpartum care. And for other barriers, we're looking at inadequate human resources when it comes to the key personals that will attend to births, and of course manage pregnancy, like midwives, doulas, OBGYNs, and patient navigators. We're looking at inadequate equipment, delayed care, lack of transportation, closure of rural hospitals and obstetric clinics. So the team and I, using literature and of course looking at the community, we came up with this root cause analysis and the gaps that are there, and of course how we're going to fix it. So how are we going to fix it? We have an action plan. The action plan brought clinical and non-clinical team, this multidisciplinary team together. So after our root cause analysis, we use this project planning form to help us to think systematically about the improvement project, and included listing of the changes that the team is testing. So we're still using the plan, do, study, act cycles for each change. We are assigning people who are responsible for each test of the change, the time frame for each test, the team. This form allows the team to see everything at a glance. So we know the objectives, the process measure, the goals, the drivers, the change ideas, the tasks we have to do to prepare for the test, the testing, and of course the person that are responsible. So it's a scientific method. It's an action-oriented learning, and we test it, change, revise it, test it again until we get it right. So we're going to plan the test, implement the test, observe for the results, and act on the results. So it's important to engage the team from the beginning. This multidisciplinary team will be formed to gauge, the team's buy-in. In this case, we're looking at the community, monitor for any barriers or any enablers that will help us with this project. It will, the roles and responsibility for each team is delineated for everybody to know, because it would define the lines of authority, communication, decision-making. The objectives are specific, timed, and measurable. And according to IHI, the first process is to state a measurable specific aim, and it helps us to mobilize resources and personnel and establish measures. So as from the objectives, we want to regularly assess early entry into prenatal care weekly. We want to regularly assess patient barriers to care weekly. We want to streamline system daily to make it more accessible for patients. We want to ensure retention of patients throughout the prenatal care and postpartum daily. And of course, put measures to evaluation and to sustain the project. Even after we leave, that the community will continue to do this. So the process measure is that we're going to look at percentage of pregnancy-related deaths on the day of delivery. Also, percentage of pregnancy-related death on the days 1 to 6 postpartum. We're also going to look at percentage of pregnancy-related deaths on days 43 to 365 days postpartum. And then, of course, with the sustainability, we're going to look at percentage of overall pregnancy-related deaths in 12 months post-project. And our goal is to decrease pregnancy-related deaths on the day of delivery by 10% from 16.9% in a year. We're benchmarking this with the CDC data. We're going to decrease pregnancy-related deaths on days 1 to 6 postpartum by 10% from 18.6%. And we're decreasing pregnancy-related death on days 43 to 365 days postpartum from 5% from 11.7%. And overall decrease in pregnancy-related deaths by 10% from 31.1% in 12 months period. So like I said, the benchmark where we're getting the data, the benchmark is from the CDC data. So we're going to use that as a benchmark with our goals and the process measure. For the task, the change, to implement the quality improvement initiative, we're going to kind of get all the community, the community staff, educate them about our action plan, get the buy-in and permission from the community key stakeholders, identify teams and champion, monitor staff knowledge, and make sure that the responsible team knows. So in this case, it will be me, the team lead, with the patient educators. We have nurse educators, director of women health, director of health promotion, and OBGYN, and of course HR, because we intend to add personnel as part of our action plan. We're going to initiate the plan for marketing services because we have to market it to the community, provide part of the clinic visits in the community to provide free pregnancy testing and counseling, and use technology strategies to notify patients about appointments. Sometimes it's not that people don't want to come to prenatal appointment, it's just the timing and they may forget. So we're going to use technology to notify them. We're going to establish patient navigator positions that will work on helping to keep contact with the patients on one-to-one, coordinate the care of patients. We're going to utilize presumptive eligibility with Medicaid to make sure that everybody can access care, eliminate barriers and employ more doulas and midwives and women health nurse practitioners that will help. Another thing the team wanted is to expand clinic visits, so instead of the usual 9 to 5, we want to start early, maybe 7 a.m. and end 7 p.m. But of course, we have to get permission from the community clinic management team, collaborate with them to do this. We're going to use internal and external stakeholders, key stakeholders, as we do this. The community is very important because the community leaders can help us with our marketing. So we have to keep them abreast of our project and the goals. And of course, we'll discuss impact that it will have. We're monitoring, because this is a A3 with Pdsa built in, so we're constantly monitoring using data from patient scheduling, patients notifications, data. We're going to use financial data like billing. We're going to also look at human resources data to look at our personnel, if we're retaining them, how we're retaining them, how we're getting them. And of course, this is all hands-on, so it's not just the team lead, the whole team will be involved in this initiative. One of these that we need to revise the mission, the vision, the values, and the policies of the community clinics to make it a priority for the whole clinic, that prenatal care is a priority. So in service of the whole team, medical, nursing, ancillary staff, on the mission, the vision, the values, we're going to monitor ease of integration. So we could just start, we have to take into consideration that people can be leery about change. So we're going to monitor the ease of integration by getting that loophole feedback from staff. How are we doing? What are we doing right? What are we doing wrong? And of course, the whole team will be part of this. The most important thing that actually the team thought about is that after we establish this, will it continue? We want it to continue because we will be measuring this 1 year to get our goal of decreasing pregnancy-related deaths by 10% from 31.1% that CDC usually report for a year. So we're going to make sure that our key, like the senior management and the key community leaders are involved, and we're going to constantly, showcase our results, especially return on investment. We're going to continue data collection and comparison and benchmarking it with CDC data. We're going to continue ongoing staff training, and until that mission and the vision of prenatal care as a priority is entrenched in the practices of the community. So that will be our sustainability plan for the project. For the for the project, as I mentioned before in the presentation, there are monies, there are fundings out there that will help us as we plan this project and this initiative. So it's estimated that this project is cost effective with a high return on investment. The financial obligations that will stem from this project will be worth it. The maternal and child health are priority. And funds for this project will be obtained from all those federal programs that I mentioned. We will write a grant and we will ask, and the probability of getting money is high because we're going to align our goals and objectives with the what they're looking for to give the money. So we're going to use this funding from the Preventing Maternal Death Supporting Maternal Mortality Review Committees. They usually give 150 to 550,000 a year, or we can ask the state-based prenatal quality collaboratives. They usually give 200,000 annually. We can ask the National Network of Perinatal Quality Collaboratives. They usually give like 228,000 annually. Another initiative that actually helps with, the personal aspect of it will be the Stop the Clot, Spread the Word funding. They usually give like 365,000. We can also ask the Maternal Child Health Services block grants that usually give over 6 billion in expenditures to federal, state, local, and other funds for maternal child health. So they likely will give money, especially if it's more of community type of intervention. The Alliance for Innovation on Maternal Health Community Care Initiative also has money. They usually have 5-year cooperative agreements to a total of 1.83 million in annual fundings to for strategies to decrease maternal mortality. The Healthy Start Initiative supplemental funding gives like 12 million in supplemental funding to up to 140,000 per year. They usually award to 85 recipients. So we will also be applying for that. The Rural Maternity and Obstetric Management Strategies Program funding has a 4-year cooperative agreement up to 600,000 funding for a first year with a total funding of 1.8 million. So we have money. We can get this money if we write the grant and of course align it. The other tools are like State Maternal Health Innovative Program that usually give it like 2 million in annual funding. Supporting Maternal Health Innovation Program also give like 2 million. So the cost benefit ratio shows that association between the cost and benefit of this project that is measured by the projected benefit of the present value divided by the present value of the cost, that is more than 1. So in this case, it's like 6. So the community is going to gain and for any of the intervention that will reduce maternal mortality. And as you can see from the budget that it's presented, that when we get the money from our funding, or even before that we can start, that at the end, we're the cost benefit comes from the fact that yes, we're spending money on getting technology, hardware, software, marketing materials, and all that. However, in the long term, you're going to decrease maternal mortality to 800 million. And we're going to decrease central events, lawsuits, hospitalization, medication errors, staff attrition or discipline. CMS will give us money because we're meeting provisions of quality, value as opposed to quantity. So all this money funding will go into making sure that we are getting what we need, that we're getting our new employees, especially the midwives, the doulas, and the navigators, that will help to make sure that we continue to sustain this initiative. So let's look at the impact, because the impact is immense. Community-based care is an important component of providing a continuum of care for low-resource communities. The health and well-being of women and children and newborn, they're inherently linked. So when mothers are malnourished or ill or receive insufficient care or even die, their newborns don't really do well. A mother's death during childbirth significantly raises the risk that the child will not survive. So we're not just looking at maternal, it crosses into children too. So better health requires that women have ability to access quality care from conception of the pregnancy to delivery to postnatal. And of course, this affects their children. So coordinating care is very important. The program will have a desirable impact by meeting the requirements for the 4 pillars of public health, healthcare, which includes care management, quality safety, public health, and health policy. So we're going to look at, the national action plan that focuses on improving health literacy. So with this, we're training our patients with the project. So patient will get information about the pregnancy and of course the complications that come with it. We're not just teaching our patients. The 4 pillars of National Action Plan is actually to improve population health by collaborating with the patients, but the families, the communities, the organizations, the professionals, the policymakers to improve health literacy. So the initiative met the prevention, the science, the care of medically underserved, and interdependence through the goals to disseminate accurate and culturally congruent information to meet all patients' literacy level. You think about another initiative, the CDC 618 initiative that collaborates with the community and public stakeholders to control healthcare costs while improving quality healthcare for 6 common and costly health conditions with 18 proven interventions. So one of these conditions is unintended pregnancy. So our initiative is going to meet this. The CDC 618 initiative uses best practices and evidence-based intervention to provide quality, cost-effective, and preventative healthcare to control chronic illnesses in diverse populations. Finally, the AAA initiative by the Institute of Healthcare Improvement focuses on improving population health and patient experience by reducing healthcare costs. This initiative integrated the 4 pillars of public health because the initiative demands that organizations and providers manage the care of patients to avoid waste that might jeopardize the safety of patients and the public, the community. The initiative insists on identifying and targeting at-risk population and using evidence-based research and metrics to plan care for the population. So the initiative encourages patients to be partners in care of their disease management, and the community providers and hospitals will support patients through education, motivations, and treatment of their condition. And on top of that, apart from meeting these public health initiatives, the community clinics will increase their reimbursement from Medicaid and Medicare, Centers of Medicaid and Medicare, because they're qualifying for federal health reform provisions, their medium quality improvement guidelines, and of course, they're streamlining services to minimize waste that will normally not be cost effective. So the impact, this program impact is immense, not just for our patients, but for national. It will help decrease mortality morbidity rates in the community. It helps women and children. It will help families. It will help communities, and it will help globally to decrease, and of course, to use the interventions that we've learned from other countries to reduce morbidity and mortality in this population. So programs, I mean, no matter how good it is, if it's not evaluated. It's really not, you can't really tell if it works. Granted that we already have the Pdsa in our A3 and of course in the action plan, we also want to use CDC prevention evaluation framework to actually look at this program. So effective program evaluation is a systemic way to improve and account for actions. It involves procedures that are useful, ethically, ethical, accurate, and feasible. This framework is practical. It's a non-prescriptive tool, and it's designed to summarize and organize essential elements of program evaluation. It has steps in program evaluation and standards of effective program evaluation. And we adhere to these steps and standards. It will allow us to, the team and I, to understand each program's context and improve how the program evaluations are conceived and conducted. So the specific purposes of framework are to summarize and organize the essential elements of the program evaluation, provide a common frame of reference for conducting effective program evaluation, clarify steps in program evaluation, and address any misconceptions about the purpose and the methods of the program. So the steps of the evaluation practice, we are going to engage stakeholders. These are people that are involved in or affected by the program, like our patients, the community, and all that, and the primary users of the evaluation. So we're also including staff from the community, from the clinic, those that are involved in the program operations. So we're going to engage them, going to describe the need. So we did this, the program has an action plan, we engaged everybody, but we also describe the program to the key stakeholder, to the staff, using activities and training and all that. And then the program was able to assess issues. So we actually did community health assessment, and we're asking, what are we going to evaluate, right? And what framework we use. So we did use our the framework, and we also use process measures with criteria and metrics. We defined it and what will be measures, what are the goals that we're looking for to ensure that those metrics matter. And if the metrics are success, and we're using the benchmark, the CDC benchmark, to kind of see if our goal are meeting that benchmark under it or going over our set goals. And we're using evidence-based, so accurate, high-quality data from CDC and World Health Organization, which I'm going to put in the, I'm going to give the link so that you can actually see for yourself that we're using the data to gather perceptions of credibility to indicators, sources, quality, quantity, logistics, so data mining. We use the data mining to make sure that we have the right data, valid data. Also, our process indicators. So our metrics provided evidence of the action steps that were going to be implemented according to the plan. We the outcomes, the short and the long-term outcomes were also defined. The main thing is that our long-term outcome, we want to really sustain this. So we're going to, for evaluation, we'll use community health data, electronic health data, community surveys, program attendance, policies that were enacted, partnership quality assessment. We're going to measure the extent to which those metrics were achieved and progress through the goal. So again, this is why we embedded the plan, do, study approach into our A3 and of course into the action plan. And of course, justify the conclusions. We're linking the conclusions to the evidence gathered and judging them against our benchmark. Did our results fit with the metrics, the drivers, the objectives, the conclusions, what do we use, justify that conclusion and our interpretation, and of course, recommendation. And of course, we can do all the initiatives and the program we want, but if we don't share it, how will people know what we did? So we're going to use feedback to expand and change the program at any point. That's why it's important to have that loophole feedback to not wait till the next cycle. So if we do it, actively, so that with the result that is learned will be shared with the stakeholders, with the community, with the clinic, with the hospitals. It will be a format that stakeholders and community members will be able to easily access and understand. So we're going to simplify this so you can use charts, run charts and all that to make sure that they understand our findings and the changes and the process. The evaluation will contribute to the evidence-based impact of interventions to address maternal mortality. So the impact of the program implementation strategies must be communicated to all stakeholders. And central to this framework, that even Joint Committee on Standards for Education Evaluation, that the 4 standards for effective evaluation are the utility, did it serve the information needs of intended users, the feasibility, is it realistic, is it prudent, is it diplomatic, is it frugal, how about propriety, do we behave legally, ethically, and with regard to the welfare of those that are involved and are affected, and how accurate we reveal or convey any technical accurate information. And I can tell you that the team and I worked very hard to make sure that we met this utility, feasibility, propriety, and accuracy to make sure that everything is handled. Again, we're mindful of Joint Commission mandates, CMS, and of course, HIPAA and human rights. So everything will be taken into consideration when we're implementing this program. Okay, so finally, these are the links to the data sets. Please feel free to look through it. Again, the big data, it links to the big data from CDC and World Health Organization. And as I mentioned in my presentation, that even though as we're mining the data, we kind of looked at the shortfalls of the data and some of the things that we think that can be better done to collect data for this population. And these are the references, a lot of references, but these are the ones that are cited for the presentation. And this is the end of the presentation, and thank you. Again, I enjoyed giving this presentation and I hope that you enjoyed it as well. Thank you.